introduce our next speaker, who is in fact going to talk about data from Wuhan, and I think he will introduce Professor Mingxing during his talk, and I want to introduce Dr. Jing Deng, who is at UCLH and St. Bartholomew's Hospital. And I think this is really topical to the conversation we've just had, and the talk is about what happened in Wuhan and why so many healthcare workers became infected. And I guess the other side to that, of course, is, how can you stop it happening, is the obvious question we want to know about, because already in our department we have a number of people who have tested COVID positive amongst the junior staff, and we have 14 of our registrars or middle grade doctors off sick at the moment. It doesn't take that very many people to destroy a rota, so very much looking forward to what you have to say. Thank you, Jing.
Thank you, Tom. Hi, could I start my talk by introducing Professor Mingxing, who is the director of ultrasound in Wuhan Union Hospital, where for the first wave of staph infection, they got over 100 staph infection confirmed, with 150 further cases suspected. So it's the most worst hit hospital in Wuhan from the first wave, and where the human-to-human transmission is not made public. And so my first talk is actually about his research. Could you say something? Hello from Mingxing?
Okay. Hello. Thank you, everyone. I'm Professor Mingxing, Director of Ultrasound in Wuhan Union Hospital, Wuhan Medical College. We have conducted a study on ultrasound staph infection. Fortunately, the epidemic situation of COVID-19 in our area has come down. Now, I would like our college guest professor, Dr. Jing Deng, to present the findings on our behalf. Thank you.
Thank you very much. And so that's the first part of my talk, is the research by Professor Xie. And it's started by questionnaire. So the questionnaire was sent to 42 ultrasound departments in the epicentre, and they received 1,200 staff responses and found 43 staff infections. And if we spread out the findings and by age 20 and 30, these two groups have most infections, and by gender, and most infected staff were female, and that's because the workforce is probably predominantly female rather than females more vulnerable to the virus. And next one is the staff roles. And the most affected staff are scanning staff, either sonographers or sonologists, and followed by reception nurse and other people. And if we talk about the severity, most of them are fortunately with mild or moderate symptoms, but we do have the severe and critical cases, and the number is actually 5. And regarding the scanning area, the most infected area is not on the ward, not bedside, it's actually in the general scanning room. And in terms of designated hospital for COVID treatment or not, and obviously it's the hospital for COVID got most infection, staph infection. And also, if we talk about the degree of protection, if you do not wear anything protection at all, that's the period when the human-to-human transmission was not made public. And even you wear the first degree of protection, you still get a large number of infection. But if you wear the second degree of protection, the infection would much dropped. And when we talk about when the people get infected, and the key point is 20th of January, when the human-to-human transmission was made public, and the 23rd is the lockdown of the city Wuhan. So before 23rd, we got a lot of infection, and after 23rd, quite a number of infections was because the PPE became depleted. So there's no sufficient supply. And let me go back. So the main conclusion is that the insufficient early warning, insufficient PPE stocking, and insufficient scanning space are to blame for the high infection. And the second half of my talk is about the health care workers' infections and the deaths over the entire China during the outbreak. Of course, it's quite difficult to get information about the every staff infection, but we do have the chance by looking at the obituaries to find details about 41 medical staff who died on Jing. And let me spread out. The first one, if we look at the people who died directly by the COVID, we have two categories. The first category is people or staff working at fever, cough clinics or infection wards. I call it FECLIN. And in this group, we only got Gabriel's, it's blocked my view, 6 deaths. But if we look at people working actually in non-FECLIN departments, we've got actually double deaths. So that's striking. Only 33% died in the department you thought you would have more staff infection, but actually 67% people died actually in this department. That's just one thing. The second thing I like to say, the average age or the medium age of people died by COVID among the medical staff, 53 is not for elderly people, including this very famous case, the whistleblower Wen Liang, and he died just 34. And next one, the people who died not directly because of it, and you got a traffic accident because you are rushed to rescue people. You got exhaustion, which brought other problems like infection, stroke, and the various things. So among these people, the medium age is 53. That's too early. Let me compare the people not directly caused by COVID, they're not directly caused by COVID, or directly caused by COVID. You can see it's half to half. So the conclusion, so it's not just the COVID get them, it's other things when people dealing with the high distressful situation which caused the death as well. Now, if we got a chance to look at the staff infection, and we can find out a pattern. And the first paper published in the JAMA by my classmate, he studied 138 hospitalized COVID patients and they found 40, which is 29% of medicals who acquired the infection at hospital, but 31 from non-FECLIN departments and only 3 from fever departments and 1 from ITU COVID bay. And also another case from Professor Shear's hospital, the first 15 staff infections and 14 of them are not from infection department, not from fever clinic, but from neurosurgery. And also I try to get information as much as possible because I'm from the area, Wuhan, and so I asked classmates, former colleagues in various social groups, and I got the response the same pattern, which is FECLIN medicals were least hit by the outbreak because they knew what's going on and they put their face masks on and they're allowed to put face masks on because they are dealing with infection agents. But in other departments, because you're worrying about cause unnecessary fear, so if someone dare to put facial masks on, they will be cautioned. And if someone spreads news about human-to-human infection like Wen Liang, he will be cautioned by police. So that caused a huge staph infection. And first staph infection internal release is on 28th of January, which already got 1,000 cases confirmed. And the first case is actually 1st of January. And only publicly released figure is on 15th of February, and by National Health Commission, that over 1,700 health workers infected. And if you look these numbers again, and most infected people or staff that actually is here, we're thinking about the incubation period. So even if this is after a lockdown, I still think that people actually get infected before the human-to-human transmission was made public. And let me just go to another slide. It's actually, if we talk about Wuhan, the overall infection is about 2.2, which is quite heavy, but the ultrasound department got a 3.5% infection. I think that's because we were working in the confined spaces, and we have a zero social distance. We just in direct contact with patients. So that's a very high risk provision, and needs a higher priority for PPE provision. And also, if we look at the worst hit hospital, which is Wuhan Central Hospital, they got over 230 infected staff, and the worst death rate as well, got 5 people died, including women and baby. And the reason is because they were disciplined if they dare to put facial masks on. But the discipline is something very good if we look at the overall infection. During the rescue methods, the government sent about 43,000 volunteers, medical volunteers from other area of China, and they got non-infection. So the reason is they are well equipped, and also they were well disciplined. So that's my message to the Winter Lodge thing. Thank you.
Jing, thank you very much. Gosh, that was an amazing overview, and I think highlights a lot of the concerns that many people have, to be honest, about what we should be doing. A few points, really. I mean, can I just talk to you about a few of them? Clearly, you said that there are more infections associated with people not working in the fever clinic. So one suspects, therefore, that a lot of people were infected by people they did not suspect had coronavirus when they saw them.
Yeah, that was true.
Okay. So I guess it begs the question of how on earth then do you know what personal protection to wear? Because the other thing that your talk highlights is that if you're sitting in close proximity in an ultrasound room, you are at high risk. That's clear.
That's true.
So you are in a relatively high-risk situation, and it seems that you can't always know if a patient is going to be positive or not because they don't have very many symptoms. So how can you therefore know what grade of PPE to use? Because you talked about grade 1st degree and 2nd degree, and you described 25 cases when people were wearing 1st degree protection, which I presume is just a surgical mask and nothing else, and 3 cases with 2nd degree protection, which I suspect is some kind of N95 mask and other equipment. Am I right?
Oh yeah, I got slides to show the degree of protection.
So I think it's absolutely
correct.
key.
Yeah.
It's absolutely key that sonographers in private practice or wherever
know
what to do.
In China's standards, and the 1st degree of protection is already including isolation gowns.
Right.
Yeah, and also cap, and the surgical masks.
Right, and 2nd degree protection.
And that's also including the cup over, including the facial and visa. You put on the visa.
Visor and what type of mask?
And that would be FFP2.
Right. So. Yeah. In China, given this experience then, what are we telling sonographers that they need to be wearing then, based on the Chinese experience? Because the message I've got from you is, most of these infections happen, as I say, when you don't expect it, and sonographers appear to be at high risk because of where they are. Should they be demanding a higher level of personal protection, or should they be accepting just wearing a normal surgical mask?
Oh, it's actually two things. First thing is the transparency about what was really happening over there. It's not realistic when there's no outbreaks. Over there, you ask people to put on the protection. But if the information was already available, it's not distributed among the medical people, and then that's another issue. So for the increased likelihood of infection, such as the situation here in UK, you should wear the facial masks and also an isolation, not gown, at least isolation, and long sleeves on the arm you use scan patients. I think that should be what we should recommend.
I don't want to go on too much on this because we'll come back to questions at the end, but I know other people are interested. Liona, can I bring you in? I mean, what are you wearing in Hong Kong when you're in close proximity scanning patients? What advice, because I'm not quite, we really need to nail this down because it's one of the most common questions we're getting. I'm a sonographer in Sydney, doing a private list. What exactly should I be wearing?
Right at the moment, as I mentioned before, we need to do appropriate screening. We need to make sure the patients, the women are coming in without symptoms, and we need to check the travel history, contact history of the patient, and so forth. So once we've done that first screen, we feel comfortable that these women are coming into our scanning unit, then actually we are only wearing a 3-ply surgical mask, a level 3 surgical mask, and we are also advised to wear glasses all the time. If you feel uncomfortable, you can wear goggles, but we're not wearing gowns. But then, as Dr. Chan mentioned last week, we are all changing into work clothes. So we're not wearing our own clothes, we're wearing work clothes, and we're wearing goggles or glasses and a surgical mask, knowing that the patients are of low risk. This is what we're doing routinely in our ultrasound department.
I think the concerns people have is that perhaps these patients, do you have a feeling that some patients have got such minimal symptoms they don't actually declare them, or they just have no symptoms? I mean, but clearly, I mean, that's their worry, that they've got a patient in front of them, and the way things are going, a travel history, frankly, is becoming meaningless in London, or whatever. What is it? Yeah. In fact, you would be taking a travel history and not wanting them if they came from London. So that doesn't mean very much to anybody anymore.
But then it doesn't mean that everybody should be doing N95 or FFP2 for all patients. So I think that is absolutely impractical. And right now, we are obviously relying on our patients, to be honest. This is something that we see on television. We promote, we make sure that patients are honest, and that they will be persecuted if they're not honest.
Okay. Oh, cool. No, fair enough. Okay, thank you. Jing, thank you. I think for the moment we're going to leave this subject, but we are going to come back to you at the end if that's okay. I'm going to hand over to Christoph to introduce our next speakers if that's okay.